Hello, my friends. Today we're talking about NG tubes, how to take care of them, what's the standards for inserting one, what do you have to do before you use it, and so forth. We're also going to do some vocabulary. Y'all, nasogastric, naso, nose, gastric, stomach. These are tubes that go through the nose into the stomach. Any tube that goes through the nose into the stomach is used to put something in or to take something out. Okay, so that's what NG tubes are used for. Let's talk about that. That's coming right up. Hello, Clinic Review families. Dr. Sharon with Clinic Reviews. I'm excited to talk with you about NG tubes today. I don't know if excited is the right word, but we're going to be talking about them. Very common, fundamental type of a skill and knowledge that you need to know. This is coming out of the Blue Book. It's right there. The name of the Blue Book is the Blue Book, y'all. You can buy it on Amazon. You can get the Blue Book app if you go to clinicreviews.com. The YouTube channel is part of the bigger Clinic Review organization, which was started by Mark Klimek, the GOAT himself. He does the NCLEX reviews. He does on-demand and in-person reviews. You can go to clinicreviews.com to find those. We do small group tutoring. I do part of that, 4 sessions a month. And it's just, you purchase like 1 month at a time. They're also recorded, so you can watch them later if you want to. And we have our streaming service. Our streaming service is videos that you see here on YouTube, as well as other videos, and there's no commercials with those. Pretty reasonable price. All right, let's go ahead and get started. I already told you what NG tubes are in the intro to this, so let's start doing some questions. A nurse is preparing to insert a nasogastric NG tube in a patient. Which of the following is the correct initial step to determine the appropriate length of the tube to be inserted? Measure from the tip of the nose to the umbilicus. No. Y'all, that is not right. Don't do that. Okay. Measure from the tip of the nose to the xiphoid process. Okay, that's part of it. That's not the complete thing. Measure from the tip of the nose to the ear, and then from the ear to the xiphoid process. There you go. That's the right thing. Tip of the nose to the ear, usually the back of the ear, kind of wrap it around the ear, bring it down to the xiphoid process. That's how you know how far in you're going to go. And then you mark it. Measure from the tip of the nose to the ear, and then from the ear to the mid-clavicular line. No, absolutely not. So C is the correct answer. So make sure you know how to measure. You have to measure before you insert it to see how far you're going to go, and you mark that before you insert it. When preparing to insert an NG tube, which patient position is most appropriate to reduce the risk of complications? Fowler's position, with the head of the bed elevated 45 to 90 degrees, yes. Supine with the head flat, absolutely not. Left lateral with the head elevated, no. Prone with the head turned to the side, no. You want them sitting up, and if they can, they put their chin down. If they're awake, put their chin down, and if they're awake, they can swallow while you're putting it in. It's not easy to put one in someone who's awake. They are not happy with you if that's what you have to do. Which of the following methods is considered the most reliable for verifying the placement of a nasogastric tube before beginning a feeding? And you have to check placement before you put anything in, y'all, because even if you got a chest x-ray initially and you're like, it's in the right place, that's why you have to know how far it is. You mark how far it is, you mark it. And if it's pulled out and you have to push it back in, you have to check placement. You have to check placement before you give anything, because you got to make sure it's in the right place. All right, is listening for air insufflation over the stomach. Well, that is a fairly unreliable way to know. Aspirating stomach contents and checking the pH. Y'all, that is absolutely 100%. You can be certain it's in the stomach. If you have an acidic pH, I don't remember the exact number, but if you have an acidic pH with aspirating stomach contents, you absolutely do know it's in the stomach. Checking for the return of gastric contents. Again, that's okay if you are never going to be putting anything in it. So if you put an NG tube down, you hook it up to suction, and you get gastric contents, you're like, okay, it's in the right place. But that's because you're not putting anything down it. It's not an appropriate way to check if you're putting things down it. And we're starting a feeding here. Asking the patient to speak, that has nothing to do with it. So the best way out of all of these, the best way is to aspirate stomach contents and check for the pH. That's standard of care. How often should an NG tube typically be replaced to minimize the risk of complications such as infection or tube occlusion? So some people have long-term NG tubes. Every 24 hours, every 48 to 72 hours, every 2 to 3 weeks, every 2 months. So the answer in the blue book is every 2 to 3 weeks. That's the answer in the blue book. However, if they give you further information, like if it's been rubbing on the nose and they're starting to have skin breakdown there, you can replace it, y'all. This is just standard of care. No complications, everything's fine. There's no skin breakdown. Do you have to change it? Yes, you still have to change it every 2 to 3 weeks. Even in the absence of other complications, you still have to change it every 2 to 3 weeks. What is the maximum suction level used to decompress the GI tract via an NG tube? So decompress the GI tract is when we want to rest the gut. So people come in, they have a small bowel obstruction, they have an ileus, they have unknown severe vomiting, for unknown reason, we might put an NG tube down to decompress. We're giving the gut a chance to rest. That's decompressing it. Okay, so what is the maximum suction? The maximum suction is 25 millimeters of mercury. A student nurse is preparing to administer medications through an NG tube. Okay, which of the following ways are appropriate for the student to ensure the tube is in the proper place? Okay, so the student is preparing to administer meds through an NG tube. Which of the following ways are appropriate for the student to ensure the tube is in the proper place? All right. Test pH for gastric contents. Well, we know that's a good way to do it. Administer the medications and monitor for coughing. Absolutely not. No, no, no. That's not a way you don't go, well, I'll just give them the meds and see how they do. Nope, absolutely not. Push the tube in 1 centimeter to ensure it is in far enough. Don't do that. If it's in the right place, you don't do that, y'all. That's why you mark where it's at on the nose. You don't go pushing it in just for the heck of it. Measure external length of the tube. Yes. That's why you mark, okay? You mark it, and that's why you have to document it. Depends on your hospital what the policy is, but would have to document it at least every shift, that the external marker or the external length is the same as it has been, right? And so there's a centimeter marking on the tube, and you have to document that at least every shift, depending on where you work and the type of floor you work on. Auscultate gastric air bubble. You can do that. I mean, you can do that. It's not the best way, but it is one way to determine that it is in the right place. A little bit unreliable, but you can do that. Request a chest x-ray. No, you're not going to, you only get a chest x-ray when it's first inserted. Okay. And so this is not just inserted, or it would have said that. So these are the ways that you can test to see if it's in the proper place. But I'm not sure. At some point, I'm pretty sure auscultating for an air bubble is going to fall off. If I had to choose between gastric air bubble or test pH or measure external length of the tube, I would choose A or D over E every single time. E is not the best way to do it. Okay, so don't choose gastric air bubble if there's a better answer. The nurse has received an order to insert an NG tube for a client with gastric bleeding. Which of the following solutions should be used for gastric irrigation? All right, so someone has some bleeding and we're putting in a tube to irrigate, right? So we're going to put something in, and irrigation means you put it in and you take it out. So it would have a second port for removing it as well. And so what are some ways to get bleeding to stop? Well, you can put pressure on it. That's one way to get bleeding to stop. And there are different types of tubes that you can put down that you can actually inflate a balloon, and it can inflate and it can compress so that the bleeding stops. That is one way, but that's not what we're asking here. This is saying if you put an NG tube down for the purpose of irrigating it for the bleeding, what type of irrigation do you put in? And I'm just telling you, I'm just going to tell you what the answer is because it may not be something you've heard of. You put in iced tap water. So as cold as you can get the water, right? You put tap water into a cup and then you put ice in it to get it as cold as you possibly can. And then you use that to flush it out because that cold constricts the blood vessels. So it will decrease the blood flow to the gastric area so that it can decrease bleeding. Okay. The nurse receives an order to begin gastric lavage. Which of the following actions should be taken? Prepare to administer tube feeding, prepare to administer continuous gastric irrigation, prepare to administer ice tap water through the tube until it becomes back clear, prepare to suction the stomach of all contents. So the question, this is really a vocabulary word. Do you know what lavage is? Do you know what lavage is? It's a vocabulary word. It means continuous gastric irrigation. That's what the word means. So if you're given an order to begin gastric lavage, you are going to prepare to administer continuous gastric irrigation. That does not mean they're having hemorrhaging. They could be doing gastric irrigation for some other reason. So the word lavage is a general term meaning continuous gastric irrigation. It's not tube feeding. It's not giving ice tap water. It's just doing a continuous gastric irrigation. And you don't suction all the contents out of the stomach. If it said go to low wall suction, then I suppose essentially that is suctioning it all out, but that's not what lavage is. Lavage is irrigating it and putting it through. The nurse receives an order to begin gastric gavage. Oh, do you know this word? Which of the following actions should be taken? Prepare to administer tube feeding through a gastric tube. Prepare to administer continuous gastric irrigation through same answers. These are all the same answers. So lavage is continuous irrigation. Do you know what gavage is? Gavage is continuous. Well, it's not continuous. It's tube feeding. It's using the G tube or the NG tube to administer feeding. That's what gavage means. Okay. It's just a general term means feeding someone through a gastric tube, whether it's a straight G tube or an NG tube. All right, that's it. It's not a complicated topic. I didn't want to make it more complicated than it is. So what are the key things for you to remember with an NG? You got to check for placement. The best way to do that is pH. Checking for the gastric contents and checking for the pH. If you're going to irrigate for the purpose of stopping hemorrhaging, you can use iced tap water. One topic that is not covered in the blue book is gastric residual volume. So I was taught, this was back in the 90s, I was taught that you aspirate gastric residual before you start tube feeding or before you give anything through it, and that you always return the gastric residual volume, and that you hold tube feeding if like the gastric residual volume is over 200. Okay, I'm just telling you what I was taught way back when. I recently read a research study that said both of those things that I just told you about how much gastric residual volume is too much and whether you should return it or discard it. Those two things, there's no strong evidence for which way you should go with that. Okay. So when I say there's no strong evidence, it's probably not going to be on the NCLEX, because NCLEX has to be based on evidence-based base, or there's no absolute answer. So there has to be an absolute answer that is possible to know the right answer, right? Even in clinical reasoning questions. That's why we teach you how to answer best questions, because you have to have a strategy for answering a best question. Otherwise, there's no way to get it right. You could argue over what's best, right? And that's why best questions almost always the most fundamental answer, because you got to do the fundamental thing. It's almost always the right answer with a best question. Anyway, you're probably not going to get a gastric residual volume question on the NCLEX, and they're not going to ask you whether you should return it or discard the gastric residual, because the evidence is unclear on that. So I just wanted to let you know why that's not something that we're talking about. And good luck on your NCLEX and good luck in school. This is August for when I'm recording this. So a lot of you are going back to school or getting ready to take your NCLEX. So good luck in all those things. Thanks for being a part of the Clinic Review family. I'll see you later.